Tonight's topic is going to be something that affects almost all prostheses that are currently on the marketplace, particularly the low-profile prostheses, and that is aseptic loosening. Aseptic loosening is the leading cause of failure and subsequent surgery following a total ankle arthroplasty. As the term implies, aseptic means not caused by infection. However, infection should always be considered until proven otherwise in the environment of a painful TAR. Aseptic loosening may occur early or late, and as such, there's a varied amount of potential patient clinical presentations. Persistent pain immediately following the procedure to late onset of pain to no pain are all potential presentations when aseptic loosening is present. One of the complicating factors is that an implant may not be completely loose, but only partially loose. We know from CT-based studies that some quote-unquote successful orthodesis may only have partial bone-to-bone healing across the orthodesis site, and therefore it's likely to imagine that in some instances of total ankle arthroplasty, there may only be partial bony ingrowth between the interface of the prosthesis and the corresponding bone surface, and this produces a cantilevering or diving board effect, as it's been called. And this, of course, can cause loosening over time. Just a few comments on aseptic loosening versus subsidence. Subsidence is where macro motion occurs and infers inherent loosening. Aseptic loosening is more along the lines of micro motion, not macro motion. Michael Glazebrook et al. Published an article which reviewed over 2,300 total ankle arthroplasties, and they found a 12.4% of failure at 5+ years, with aseptic loosening being the cause of 70% of those failures. Stephen Haddad, in a similar paper, reviewed 850 some odd total ankles with a revision rate of 7% at 5 years, also noting aseptic loosening being the leading cause of those revisions. There's been little written specifically about aseptic loosening and total ankles, although it's been a long recognized major complication of total hips and total knees, and so therefore most of what we know is extrapolated from the total hip and total knee literature. It's now believed that particular wear debris is the major contributor, but there's also probably biological and mechanical factors. Biologic response to wear debris, intra-articular fluid pressure, the implant design, specifically the low-profile implants, characteristics that are specific to the patient, unrecognized infections, and genetics certainly potentially play a role in aseptic loosening. Biologic response to wear debris has been studied extensively since it was initially recognized in 1977. It is the leading cause of periprosthetic osteolysis and aseptic loosening. Polyethylene liners, metal components, and cement are all subjected to wear and produce particles of debris, but it's the particles from the polyethylene that are most important in the pathogenesis of osteolysis. It causes a cascade or constellation of reactions that ultimately activate osteoclasts and inhibit osteoblasts. The inflammation triggered by wear debris and or intra-articular exposure to bone that's normally sealed away or off from the joint both cause an overreduction of synovial fluid and increased pressure, and this increased pressure ultimately causes abnormal bone perfusion and resultant ischemia, which of course leads to osteonecrosis, and necrosis leads to osteocyte death and subsequently and ultimately osteolysis. Immediate implant stability is of course critical in achieving strong bony ingrowth, and the different prostheses on the market have specific characteristics which help to try and achieve this, specifically using stems, pegs, keels, and in the case of the Vantage, a cage. Of course, the InBone is a modular stemmed implant which increases the bone prosthesis interface. Coatings, either porous or hydroxyapatite, may help seal the interface between the implant and the bone. Many of these patients, as you know, are post-traumatic and therefore have had previous surgeries with hardware that requires removal prior to the implantation of the prosthesis. And these screw holes may provide a channel for wear particles to flow into the bone. So it has been suggested or postulated and studied currently whether we should be grafting all these screw holes and cysts that we see preoperatively on our CT scan reports. Some factors have little to do with the prosthesis and are alternatively on the patient side of the equation. Certainly younger patients with higher activity levels, patients that smoke, use of nonsteroidal anti-inflammatories and steroids, and certain systemic comorbidities may predispose a patient to osteolysis. In any case of a loose or painful prosthesis, there has to be serious consideration given to the fact that it may be infected. This can be especially difficult due to the glycocalyx biofilm that forms on these implants and conceals them from detection. There are multiple studies that have documented bacterial DNA in the presence of a loose implant, which was initially thought to be caused by aseptic loosening. Extrapolating from the total hip literature, Mugen et al. Looked at 175 total hip revisions, and there was a 4 to 30% incidence of infection. Aseptic loosening can be a diagnosis of exclusion. When a patient presents with either persistent or new onset of ankle pain after a total ankle, again, not to be redundant, you first must rule out an infection. So take note of any history of a slow healing incision, erythema, edema, fever, and the rest of the constitutional symptoms. One clue is that pain secondary to loosening may be often activity mediated, and pain associated with an infection is not activity mediated. So if a patient only has pain when they are actively utilizing the prosthesis, this may indicate an aseptic condition, wherein if they have pain all the time, you seriously have to consider infection. Of course, in this scenario, we're going to take standard ankle films in the office and compare them serially to previous films, looking for changes in implant position, periprosthetic lucencies, gutter impingement, heterotopic ossification, developing or progressive arthrosis in adjacent joints. And typically, we will garner a CT scan, which is far superior to plain films, but SPECT CT seems to be the developing gold standard. This will show localized high-intensity signal adjacent to the tibial or talar component, which would be suspicious for aseptic loosening. Strategically speaking, surgery becomes indicated in the setting of aseptic loosening, and pain should be the primary driving factor. This, of course, is not the same in the case of an infected total ankle. If the pain is not severe or limiting in terms of the patient's activities, but there is definitive loosening, treatment may and probably must be tailored. And the decision to defer surgery is reasonable, though, as you might imagine, regular serial reassessments should be scheduled. And just keep in mind, progressive bone loss may preclude future revision. So it's okay to wait on surgery and continue to monitor these patients, but you don't want to get into a situation where future progressive bone loss limits your ability to revise these patients. And therefore, if the clinical evaluation is not suggestive of infection and there's a normal ESR and CRP, the deep infection considered to be excluded, and therefore other causes of aseptic pain are sought out. So if infection has been ruled out and plain films and a SPECT CT scan are negative for impingement, malalignment, adjacent joint disease, or HO, then aseptic loosening becomes the suspected culprit. Particularly and specifically if the SPECT CT scan shows high intensity uptake at the bone implant interface, then aseptic loosening is highly likely and revision surgery is considered. If it's painful enough, and of course infection has been ruled out, because obviously that'll take you down a completely different treatment pathway. Just remember that loosening may be present with other factors, such as impingement or HO, so the cause of pain may be multifactorial. Two quick cases, which are not my own. This is a 73-year-old female, 4 years, status post total ankle replacement with diffuse ankle pain. Looking at her x-rays, they seem to be normal, nothing overtly suspicious. So from plain films, we move on to a CT, which again looks pretty unremarkable. Demonstrates bone well opposed to the tibial and talar components. So subsequent to that, a SPECT CT scan was ordered, and as you can see here, there's increased signal uptake in both the medial and lateral gutters, with no increased signal adjacent to the implants at the implant bone interface. So this would suggest there's no loosening, and the source of pain is in fact gutter impingement, which, as we discussed before, is a fairly common source of post-TAR pain. So in conclusion, remember that aseptic loosening is not uncommon, irrespective of the prosthesis. All of these have had issues with aseptic loosening. You first must rule out, first and foremost, that there's no infection at play. A SPECT CT scan can be extremely helpful in these cases, and the treatment must be tailored to the patient. Thanks for listening. This is a similar case of a 57-year-old female, 2 years status post-TAR with both medial and lateral pain. SPECT CT scan demonstrating syndesmotic degeneration and medial gutter impingement, but no overt signs of any loosening or osteolysis or subsidence. This is the third and last case demonstrating the efficacy of a SPECT CT scan. This is a 69-year-old female, 5 years status post with persistent, hard to localize pain. Plain films depict a well-positioned and aligned prosthesis without any overt signs of loosening. The CT scan confirms osteolytic cysts under the talar component, but no definitive loosening. A SPECT CT scan pictured on the right shows high-intensity signal at the talar prosthesis interface without signal in the cysts, which would lead one to believe that this is a case of aseptic loosening.